And so, welcome, dear participant, to this symposium. Today, we have Dr. Elambius Matthias Mlugu from the Department of Pharmaceutics and Pharmacy Practice at Muhimbili University of Health and Allied Sciences. Dr. Mlugu is a seasoned pharmacist, having studied pharmacy at the University of Muhimbili before studying Masters in Industrial Pharmacy in the same university. And then he proceeded to Karolinska Institute in Sweden, where he did his PhD. And he's a recent graduate of this doctorate. And today he will be sharing with us about the management of malaria in Africa, highlighting the opportunities and the challenges. So with that, I would like to welcome you, Dr. Mlugu. Welcome.
Thank you so much, Mr. Nelson Masota, and all members of this forum. I thank you for this opportunity to talk about the malaria in general in Africa and looking at the opportunities and challenges. As I was introduced, my name is Elambius Matthias Mlugu, just graduated my PhD from Karolinska Institute at Sweden. So in this presentation, I am going to give an overall of the malaria burden and epidemiology in Africa and globally. And also I will talk briefly on the vulnerable population, mainly children and pregnant women, and why they are vulnerable population. And also I give a highlights of the findings of my PhD work. And also we'll discuss together along some challenges aligned with these different target populations. So I'll start my presentation right away. If you move to the next slide.
Sorry, yep.
Yeah, thank you. So briefly, a brief biology of malaria, that this is a parasitic disease and it's currently considered the disease of tropics and subtropics. Currently, there are 6 species known to cause malaria in human being, of which 5 are origin human species, and the recent species of simian have evolved as one of the causes of malaria in human being, known as the Plasmodium knowlesi. And this was reported in northeastern of the world. In brief, malaria involves 2 hosts, one of which is mosquito and the other one is human being. And in brief, this, or if you look at the picture on the right hand of the slides, shows the 2 alternative hosts where malaria moves around in its course of, where malaria parasite moves in its course of life. So to start with, if you look at the cycle begins where the mosquito bites human being and picks the 2 gametocytes, which are female and male gametocytes, being sucked by mosquitoes during feeding. And these gametocytes, they fuse in the mosquito body to form the microgamete, which then further forms the zygotes and ookinetes and the oocyst, and finally forms trophozoites. So the cycle again comes into human being when the mosquito again comes to feed human being, releasing these sporozoites, which invades the human body to begin with, goes directly into the liver cells where they mature. And after certain days, 10 or so, then they mature sporozoites in the hepatocytes, forming a merosomes and ruptures. The merosomes is just an encapsulation where so many merozoites in this stage, and then are released into the human circulation where they invade the red blood cells. And then here, the red blood cell cycle begins, where in the red blood cell, these merozoites invade the red blood cell and then further divides, forming by a sexual way, forming trophozoites, shy zones, which after a cycle of 48 hours, then red blood cells ruptures, release again the merocytes, and the cycle again begins. Just to note in this figure is that some of the infected red blood cells and some of the merozoites during the blood cell cycle, they commit themselves into gametes and the so-called gametocyte state. And it is where these gametes, the female and male gametes, are formed, and then the cycle again begins into the mosquito when they feed into human beings. This is a brief cycle of the malaria parasite, and it's very important. We'll just reflect on this figure, looking at which targets are we really targeting when we treat malaria. So malaria is a public health problem, despite the substantial decline globally over years. Still, it's a public health problem affecting more than 200 million people worldwide. For instance, in 2019, it is estimated that about 229 million cases occurred worldwide, associated with more than 400,000 deaths as a result of the malaria infection. Surprisingly, almost all the cases, about 94% of all the cases and associated mortalities occur in sub-Saharan Africa. If you look at this global map here, this is according to CDC reports of 2020, indicating the malaria transmission globally. If you see in this map, the area of Africa, sub-Saharan Africa mapped by the red, if you click to next slide, highlighting the map. So you see that this area is marked by the red. Sub-Saharan Africa is where most of the cases, 94% of the cases and associated mortalities occur. And we live in this area here. And most affected are pregnant women and children below 5 years. We'll see why are these populations most vulnerable. Next slide, sorry. This map here, this figure here was taken from the malaria report of 2020, WHO malaria report of 2020. It just shows the trend since the beginning of the new millennium in 2000 year to current, how malaria went on trending. If you look, the green curve shows the malaria incidence since 2000, and the red one shows the incidence malaria death rate since 2000. You see that there has been a substantial declining in both the incidences of malaria and death rates from 2000 to 2015. And this has been attributed by the number of commitments which occurred during the beginning of 2000. That was marked by the beginning of new Millennium Development Goals, in which so many interventions coming, like establishment of Global Fund, President's Malaria Initiative, and so many much more of the financial commitments came in this time, which were associated by the coming up of new strategies, new diagnostic techniques, new treatments like the artemisinin combination therapies came in during this time. And so there was a substantial declining in the malaria burden from that year, and also associated deaths. But then if you look from the year 2015, if you click next slide, sorry. If you look at the marked area, sorry, go back, sorry. If you look at the marked areas in 2015, going to 2019, you see that there has been like a stall, a declining in decrease in the malaria incidence, same to mortality associated with malaria. There has been a decline. And it is observed that the number of cases increased over this time. And also the decrease in mortality rate also decreased as compared to the year 2000 to 2015. And so this calls for the governments, stakeholders to pull up more efforts in the strategies for controlling of malaria so that we can get back on track. Next slide, please. So looking at the Tanzania, for us who are coming in Tanzania, Tanzania is actually considered as one of the 11 high burden countries globally. And the 11 countries are mostly found in sub-Saharan Africa. All of them are sub-Saharan Africa, with except to one country, which is in Asia, India. And Tanzania contributes more than 6 million cases annually, or in overall cases of malaria. For instance, in 2019, which is a similar figure recorded since 2015, Tanzania contributed more than 6 million malaria cases. And if you look on the map on the right, shows the distribution of malaria transmission in Tanzania, is that we have regions where we have very low transmission, we have low and moderate transmission. The area marked by red on the western part of the country and the southern part of the country are considered to be areas of high transmission yet. And this is according to National Malaria Control Program in 2020. So you see that we still have a burden of malaria in Tanzania. And surprisingly, if you look at this figure here, the pie chart, it shows that Tanzania was recorded as one of the top 3 countries which contributed about 36% of mortalities associated with malaria in 2019. This is very strange. Tanzania, United Republic of Tanzania contributed 5% of all mortalities associated with malaria in 2019. And so this calls for more efforts to pull up in the control of malaria in Tanzania particularly. Next slide, please. So let's look at some of the strategies which are used for the control of malaria. And the main strategy, and which was extensively implemented over years and has been strengthened from the year 2000 up to currently, is the use of insecticide-treated bed nets. And this is recorded that an expanded program of use, ITN, has contributed to about 69% reduction in malaria incidences for the past 15 years. However, there are challenges with this strategy, and one of it is the slow coverage of ITN. For example, in 2018, globally, it is estimated that 61% of all populations that need ITNs have ITNs. And this has been the same figure over the past 4 or 5 years. So you see that there's a slow coverage in owning. In Tanzania, particularly according to the recent malaria indicator survey, it shows that the owning of ITN in Tanzania has expanded to 78%. At least this is a promising figure. However, owning and using is different, and researchers indicate that the utilization of ITN is declining year after year. So this is a challenge associated with both populations, but also some control strategies, including the distribution, and make sure that those people who are supposed to have ITN will have the ITN. Another challenge is that the use of ITN, insecticide-treated bed nets, targets indoor mosquitoes. Like we use nets when we sleep inside, and we don't work with nets around outside just to protect ourselves from mosquito bite. No, we use ITNs inside when we sleep. Unfortunately, we have mosquitoes which are biting outdoor, and research shows that over the past 1 decade, there has been an increase in the species of Anopheles arabiensis, which is an outdoor biting mosquito. And usually in the past years, Anopheles gambiae complex used to be the most predominant vector of malaria in Africa, and particularly in Eastern Africa. But then there has been a substantial change in the epidemiology of these vectors, where arabiensis is in increase, actually outweighs the dominant vector, which is Anopheles gambiae. So this is a challenge. We protect inside, but then arabiensis, which is an outdoor biting, is increasing. And then it's like outweighing this control strategy. But also we have an increased burden of mosquito resistance to pyrethroids, which is the most commonly used chemical in these insecticide-treated bed nets. So these are challenges with these control strategies that need to be addressed both in research-wise and also implementational-wise. We have also an indoor residue spray, which is similar to use of I-10, but this is just spraying indoor to kill the mosquitoes and also protect the walls so that mosquitoes will not land on the walls. So the same challenge is faced by the increase in outdoor biting. Despite that we control the vectors inside, but then the increase in outdoor biting outweighs these control strategies. So it's a challenge in the control of malaria. Another strategy is timely diagnosis and treatment of malaria cases, which is faced by so many challenges. The one of it is in the changing epidemiology of malaria in Africa and globally nowadays, that their symptomatic cases are more compared to symptomatic cases. And the timely diagnosis and treatment requires symptoms to diagnose a disease and then treat. So being asymptomatic then, it means that majority of people will just be asymptomatic but carrying the parasites, which then increase the transmission cycle. So hinders the control of malaria with these kind of strategies. But also the treatment of malaria requires proper diagnosis. In Africa, we have malaria rapid diagnostic test as the control strategy, the diagnostic control standard currently, with together with microscopy, of course. But then MRDTs are the most commonly used. One of the challenges is the low sensitivities to detect infection in people. The RDTs, they have low sensitivity in detecting malaria because they need like high parasite density so that they can react positive with the antigens. And also another coming challenge is this, that the MRDTs detects the malaria antigens where they target the antigen P. falciparum histidine-rich protein 2 and protein 3. So there is polymorphism, there is mutations in this antigen, so that the targets which is in the MRDT, if the parasite develop mutation with this parasite, with this protein which is targeted in MRDTs, then we are going to have false negative. People will not be detected with malaria, but they have malaria infection, and this interrupts the transmission cycle. So in some countries, and including Tanzania, of course, the 2020-2025 strategy, malaria control strategy, is towards elimination. So to eliminate malaria, you need to interrupt the reservoir of malaria infection. So not interrupting reservoir is a challenge that need to be addressed, of course, with the increasing in the mutation of this, and also low sensitivities is a challenge in the detection and treatment of malaria. In this red information here is captured from the 2020 malaria diagnosis and treatment guideline of Tanzania, which now recognize both symptomatic and asymptomatic malaria as cases, and it requires both active and the passive detection of cases and treatment. So this is a good news if it is well implemented, that will also detect asymptomatic cases, treat them, and then interrupt the transmission cycle. So these are this slide here, the next slide, sorry. The next slide shows some of the malaria drugs which are used in Africa. And the first line malaria drugs include artemether, lumefantrine, artesunate, amodiaquine, dihydroartemisinin, and piperaquine. And this applies to almost all the countries in Africa. Of course, we have some differences in different country individual guidelines, but then the first three drugs are considered as first line treatment of malaria in Africa, where dihydroartemisinin seems to have the highest efficacy, 99.4, followed by artesunate, amodiaquine, and artemether-lumefantrine. And of course, artemether-lumefantrine is considered the first line treatment before you go to even amodiaquine, artesunate, and dihydroartemisinin, piperaquine. And we have also artemisinin piperaquine, we have artesunate mefloquine, we have artesunate pyrrolidine, which are also considered as second line treatment. But almost all these drugs, if you look at the figure now, if you refer the figure, reflecting that figure that I was telling, the life cycle of malaria parasite, all these drugs target the red blood cycle. And they target this schizont. If you see in the figure, the schizont stage is the main target of most of these drugs, rupturing and killing parasite in the schizont stage. But then we would like to have drugs which target the liver cells, of course. And this is mostly for the parasites which usually have the hypnozoite stage, like the P. ovale and P. malariae. But these, of course, in Africa have little contribution in malaria cases, about 4%. And in most cases, they occur in combination with P. falciparum infection. The most important, especially when we are going to transmission, to elimination stage, the best drug will be combating both the red blood cell cycle and the gametocytes. Because we know that even if you treat these schizonts in the blood, in the red blood cycle, then some of the parasite will commit into gametes, and then they will still continue in the cycle of transmission. So we like to have drugs which will block this transmission by killing the gametes, so that mosquito will not have anything to pick to for further transmission. Unfortunately, we have very few of these drugs. We have Primaquine, which is approved for to be a gametocide, so to have a gametocidal effect. And unfortunately, it is not commonly used, and it is not available in most of our guidelines in Africa because of safety concerns. Because most people in Africa, we have the glucose 6-phosphate deficiency, which have safety issues with this drug Primaquine. However, evidence is coming up that this drug could be safe. Initially, WHO used to say that to use this drug, you need to do tests for this glucose phosphatase dehydrogenase test so that you can use Primaquine. But then evidence is coming up, and probably in the near future, we'll incorporate Primaquine in our treatment guideline. Maybe we're going to have triple therapy, say at methylmefantine with the Primaquine, targeting the gametocytes and then blocking the transmission. We also have injections like artesunate and artemether, which are used for severe treatment. Next slide, please. Yes, a quick review of what we are doing in our daily activities as pharmacists. This is what we do. We see these patients in our hospitals, in our clinics, and this is what it's our role now to advise people on the use of medication. It is recommended that the drugs, most of these antimalarial drugs are given for 3 days, but it is recommended that the first dose should be given as a direct observed therapy in the clinic. I don't know to what extent we pharmacists practice this in our settings, but also we are advised to let patients at least for 30 minutes observe if they vomit or they don't vomit, because it is recommended that if the first dose is vomited within 30 minutes, then another full dose should be given. So it's a role of pharmacists to make sure that this is observed when we help our patients with malaria. And how, I don't know how often do we advise people to take the drugs with fat meals. I don't know to what extent our African meals also have fats, but this is very important, of course, in enhancing absorption of most of antimalarial drugs to enable the good absorption and good availability. Another challenge is that for effective treatment, the drugs are recommended as to be given basing on body weight. And for example, for the ALU, which is the first line, especially in East Africa, the recommended dose is 1.5, 1.7 at a MESA, and 12 milligram per kilogram body weight of lumefantrine. However, in our practice, I think we just base on the weight bands. For example, you find that weight basing from 5 to 14 kilograms, they're given 1 tablet, 15 to 24, 2 tablets, etc., etc. So this is a challenge, especially when we're going to see malaria management in pediatric patients. you go next slide, please. So as a pharmacist, this is our role now, looking at how often do we encounter and how often do we practice when we treat our patient with malaria. Looking at the malaria in children, as I said, that the children are one of the groups which are very vulnerable and susceptible to malaria. And why this is because these children, especially below 5 years, have low acquired immunity. You know that the malaria immunity is acquired as you grow up due to different exposure. When you get malaria infections repeatedly, then the immunity is developed over time. So these children actually, they have low immunity or no immunity, and therefore they are very susceptible to malaria infection. And for instance, in 2019, it is estimated that about 67% of all malaria-associated mortalities occurred in children below 5 years. So this is really a challenge. And then management of malaria in children is also associated with some challenges. It has been observed that most children have high elimination rates of antimalarial drugs, including lumefantrine, piperaquine, and all those long antimalarial drugs which are partners to artemisinin. And this is a challenge because high elimination rate of these drugs will actually leave children with suboptimal concentration, and therefore this might be associated with treatment failure. So it is advised that weight-based dosing should be given, especially for children and adolescents, because of this high elimination of these antimalarials. However, as I said, this is not practically possible because we use weight bands in treatment of malaria. So in children, particularly the control strategies, together with the aforementioned strategies, ITN and indoor residual spray and treatment of cases, then some countries in Africa, they have implemented the so-called intermittent preventive treatment in infants with sulfadoxine and pyrimethamine. And also I am aware that there are 2 new studies which are reported that dihydroartemisinin piperaquine is a very promising drug as an intermittent preventive treatment in infants in the prevention of malaria. Another strategy is called the seasonal malaria chemoprophylaxis. If you see SMC in the figure there, this seasonal is it includes the practical issue of this seasonal malaria chemoprophylaxis in children is actually giving a monthly dose of full course of malarial drug in the season where, in the rain season where transmission of malaria is usually high. So it is practiced in some of the countries. And fortunately, the Tanzania treatment guideline of 2020 has also recommended that research on this should be done and also implemented if possible. The challenge with some parts of Africa where we actually have multiple seasons of rain, then it will be difficult to practice this kind of strategy. The good news with malaria prevention in children is the recently reported malaria vaccine, which have acceptable efficacy. So we hope that if this vaccine is, it has already been approved, if it comes to Africa where really the problem is, we hope that probably we will not be talking about this 67% in children in the near future. Next slide, please. Yes, a bit of the parasite in paradise. The parasite in paradise is just a phrase describing malaria in pregnancy. And why are we saying the parasite in paradise? Usually, as I said, that pregnant women is another group who are more susceptible to malaria infection. And this is because during pregnancy, there are different changes in hormonal, including cortisol, progesterone, and these are associated with some immunomodulations, and therefore they are usually decline in immunity during pregnancy. And this immunity, the decline in immunity is purposely, especially prevented in the placenta. The cell-mediated immunity is reduced in the placenta, which cell-mediated immunity is one of the most important immunity for malaria prevention. But then it's lowered during pregnancy purposely because you need to keep the placenta sterile to allow the growth of the fetus. So there's no actual immunity or any kind of infection ideally supposed to be in the placenta. So the placenta is an ideal called the paradise. So the phrase parasite in paradise come in that these parasites, malaria parasites, are very tricky. When the body reduces its immunity during pregnancy, especially in the placenta, to allow the growth of fetus and avoid rejection of the fetus, the parasite goes to the placenta and hide themselves because immunity will not see them. And this is where most malaria-associated problems begins. So surprising is that the malaria parasite during pregnancy, they develop special antigens which will not develop when they infect men or when they infect non-pregnant women. This is surprising. They develop antigens which specifically binds to chondroitin sulfate A in the placenta. And this also mediates the accumulation of infected red blood cells into the placenta. So they hide in the placenta to avoid the immunity, but then they make trick of making these antigens, making them binding to chondroitin sulfate A in the placenta. And this entails all the problems associated with the malaria in pregnancy. Just to confirm how pregnant women are susceptible, in 2019, it is estimated that in Africa, about 33 million women became pregnant, of which more than 12 million were exposed to malaria, which is about 35% of all women who became pregnant in 2019 were infected with malaria. And this is an increase if you compare with 2018, where 11 million, about 29% of all women who became pregnant in Africa were exposed to malaria. So you see how this is a challenge in pregnant women. And unfortunately, most of these cases are asymptomatic, but causing so many problems in pregnant women. Next slide, please. And so this slide here just shows the effects of malaria in pregnancy. It is associated with low birth weight. For example, more than 800,000 of children were born with low birth weight attributable to malaria in 2019. And low birth weight is a risk factor for infant mortality and also low intellectual quality associated with childhood malaria and infants in anemia. So in addition to the control strategy that I just mentioned, the ITN, indoor residual spray and treatment of cases, there is intermittent preventive treatment in pregnant women with sulfadoxine pyrimethamine. Although there are some challenges of low coverage of this IPT-PSP. For example, only 34% of women received more than 3 doses or equal to 3 doses in 2019. And the main problem with this is the increased resistance of parasite to SP. And this is mostly marked in East Africa. And in some places, the mutation is more than 95%, for which the WHO says that when this is reached, then this strategy is no longer effective. So this has been a challenge, and you can imagine that failing of this strategy, which is expected to protect women, you are going to encounter all these effects associated with malaria in pregnancy. Next slide, please. So with these challenges, then this was it was a part of my PhD program where we wanted to, of course, there has been efforts to look for alternative drugs because of the increased resistance to SP. There's been so many strategies to find an alternative drug. And so many drugs, all the drugs were tested, but then they were not tolerated compared to SP. And during my PhD, then I tried to compare if intermittent preventive with sulfadoxine pyrimethamine, which is the current gold standard, with a new drug, diadotamycin peperaquine, if the new strategy could be superior. And why trying to use these ACT drugs? Because now most of the cases will be asymptomatic. If we keep these drugs for treating, and then the cases are symptomatic, and then we have low sensitivities of diagnostic tests to detect malaria, then we keep the drugs, but we don't have the cases, but the cases are symptomatic, affecting women. So there's a need to expand the role of these ACTs in preventive strategies, especially when we are approaching elimination strategies. And this was my PhD thesis, where we did a clinical trial. Next slide. And this was the paper that was published in the American Society of Clinical Pharmacology and Therapeutics. So in my PhD work, next slide, I did a clinical trial comparing the IPT-PSP and IPTP with diautomatine piperaquine, and followed women, about 956 women, randomized to 2 groups, monitored malaria during the entire period of pregnancy and adverse birth outcome until delivery, where we detected malaria in placenta cord, in the placenta, cord blood, and maternal blood. And if we move to next slide, these are the different strategies that we use. We use PCR, we use the mRNA, we used microscope to detect malaria. So briefly, this is what we found in my study. And this figure here shows the risk of malaria during pregnancy over time until delivery. And you can see that the blue curve shows that the IPTP, women who were randomized to IPT-PSP had actually higher risk of malaria during pregnancy compared to those who were randomized to IPTP with diautomatine. And this was strongly significant. If you go to the next slide. And I said that we detected malaria in all the tissue and materials, including placenta tissue, placental blood, maternal blood, cord blood, and maternal blood. And in all the materials and all the methods that we use, we found significant protective efficacy associated with diautomatine piperaquine as compared to sulfadoxine pyrimethamine. Next slide. So this table here just shows all the materials and the places and methods where we detected malaria at delivery. Same to this table. And there was strongly significant difference between the 2 groups. Next slide. And so we came to conclude that according to our findings, we found that intermittent preventive with monthly diautomatine piperaquine was superior to intermittent preventive treatment with sulfadoxine for the prevention of malaria during pregnancy and at delivery. And both the treatment regimen were equally correlated. As I said, that most of the malarial regimen that were tested, they failed because of the tolerance challenge. But then we found that diautomatine piperaquine were equally tolerated as the sulfadoxine pyrimethamine. And we found that more than 90% of women, they attained sufficient piperaquine concentration, which is the long acting partner, which is expected to provide the prophylactic activity. And we are hoping that this is a good news for malaria control in Africa, especially bearing in mind that pregnant women who are symptomatic get malaria associated with so many effects affecting even infants, but also they act as a reservoir, but sustaining malaria transmission in Africa. So if we don't have a good control strategy in pregnant women, then it's unlikely that we'll have a good, we will talk about elimination of malaria, because we still have reservoir sustaining malaria transmission, even if we reduce malaria in the general population. Next slide, please. So what are the perspectives that need to be addressed? Currently, SP is still the gold standard in Africa for intermittent preventive treatment, although we have evidences that diautomatine is a promising alternative. But then in our clinics, pregnant women are given folic acid. And you find that most of the folic acid formulations, and we as pharmacists, we know that the formulations available in our market in Africa, they are 5 milligram folic acid, which are given for pregnant women. But then the activity of SP is compromised when you give folic acid above 1.5 milligram. So looking at the practice that we do in our setting as pharmacists, giving folic acid 5 milligram and SP, actually we are compromising the efficacy of this drug. So that's just a point of information to note. But also pregnant women, because of the changes in hormonal during pregnancy, they have induction. They have induction where there is increased metabolism of these antimalarial drugs, and therefore they end up having lower concentration of these antimalarial drugs, which could be associated with the treatment failure in some cases. So this is still a challenge which needs to be addressed. And currently, with the given pandemic, COVID-19 pandemic, then there are so many challenges with malaria. Some of the challenges that need to be addressed is to what extent the malaria supply chain has been affected by the COVID-19 pandemic. Because we have seen that some of the countries where we get these commodities have been undergoing lockdowns, and most of them also, they have shifted in manufacturing diagnostic for COVID-19, medicine for COVID-19. So probably this would have affected the malaria supply chain and also would have affected the entire control of malaria in Africa at large. But also there is a hypothesis of interaction between malaria and COVID-19 that is hypothesized to be the protective factor for Africa not to be associated, not to have so many cases of COVID. The ACE2 receptor concept that has been discussed now and then. So these are the issues that need to be explored. Research needs to be done more, as the COVID-19 pandemic is still new, but then it would also impact our efforts in the control and elimination of malaria. So these interactions need to be studied more. The most important thing is the placental malaria vaccine. We have seen that we have a new vaccine approved recently, but this will not protect women. Bear in mind that we said the most effect of malaria in pregnancy is because of these antigens that they develop, which bind to chondroitin sulfate A in the placenta. So we need vaccine for placental malaria in order to effectively control malaria in pregnancy. We need a dedicated vaccine against these antigens binding to chondroitin sulfate A in the placenta. And I am aware that there are 2 vaccines which are in phase 1 trial. And the results are not bad, but then there are still challenges because of the multiple antigenic targets with the placental malaria issue. So whether vaccine will be the final solution, or whether vaccine with intermittent preventive treatment with SP or diarythromycin piperacin, this need further investigation. And with these few remarks, I think marks the end of my presentation. And thank you so much for listening. And you can reach me via my email and my mobile number. Thank you so much.
Thank you very much, Matthias, for presenting so well about management of malaria in Africa, opportunities and challenges. I believe the presentation was very, very insightful, and every one of us has got something in addition to what he or she knew previously. So now the presentation is very open for discussion and questions. If you have a question, you have 2 options. You can switch on your mic directly after raising your hand, of course. There is a raising hand function here. Or you can type your question on the chat box and I will read it for you. So if you have a question, you are free to go on by raising your hand or typing it. Welcome. Maybe because while people are still typing and they're rephrasing their question, I have some ice-breaking questions here. We used to have outdoor spraying campaigns back in Tanzania and some other parts of Africa. I would like to know what were the major blocking factors for this campaign not to continue today, and if they are still viable.
Yes, Masota, thank you so much. And actually, this was a larvicidal spray.
Yeah.
Spraying, targeting the larvae of mosquitoes. And I think it's in good state, just that there's some challenges. There has been some supported programs, especially in those countries which are highly affected with larval transmission. And we also have a biotech industry in Tanzania manufacturing this larvicidal biotechnological in Kibaha. So it is still going on, and I hope we need to scale up. We are not doing to the best of our capability. We need to scale up, especially now that we are talking of elimination. This will not be achieved if we target both sides. We target especially the transmission cycle. This will actually help. We need to scale up, so to say. That's what I can say. we are not doing to the extent that we are supposed to do.
Okay, thank you very much. I see the hand of Sospita John. Sospita, you may proceed to asking your question, please.
Thank you very much, the moderator of the presentation, as well as the presenter. My question, according to the presentation, first of all, I would like to congratulate you on what the presentation contained. It is a new idea that really, according to the presentation, shows that it has something that is very, very essential for the community. I think it is also better as academicians and stakeholders in the farmers profession to share the information to very crucial people who are decision makers for coming up with changes if it is in the treatment guidelines and whatsoever. But my question wanted to know why, according to the presentation, what I saw, it seems that there is an increase in malaria transmission in areas in Tanzania, in areas in the southern part of Tanzania as well as the western part of Tanzania. Now, I wanted to know what might be the real cause, because as it was seen from the presentation, it seems the people from the lake zone are a bit safer than those in the western and the southern part. Now, I wanted to know what might be the leading cause for this population to be highly affected to that extent. Thank you.
Okay, thank you very much, Sospita. Matthias, you're welcome.
Thank you so much, Sospita, for the comments, and for just information is just let you know that our findings was really seen by WHO, and we were contacted by WHO, and we are doing a individual data meta-analysis to see if this, all the guidelines are coming from WHO. So WHO wants the evidence to see if this strategy would really work better and it could be incorporated in guideline pool. So we are currently working on the individual data meta-analysis with some partners in the WHO. And we hope that these findings will actually pave way for more guideline, especially in endemic countries, including Tanzania. Just coming to your question, it is true, as you saw in the map, and this is a very recent malaria map that was given by the National Malaria Control Program, that we still have some foci with high transmission. Really, I cannot say why these areas, because it's sometimes fascinating to see the zones with low transmission, the zones with high transmission. Probably there is suboptimal implementation of the control strategies in these areas, especially the southern areas, which have been really neglected in the past, but now I think they are taken together. These areas are probably the suboptimal implementation of the control strategies. And of course, if you look at the individual data, looking at the coverage of ITNs, the coverage of ITN and the implementation of ITN, these areas have low, actually, they have low coverage of ITN. So to say, what I can say is that there is a suboptimal implementation of the control strategies. And of course, the National Malaria Control Program now is putting more efforts into these areas with high and moderate transmission to make sure that we move together, because we cannot talk of elimination if we still have red areas marked with red with high transmission. So I think there is now increased, the efforts are put more on those areas to ensure that the transmission is declining and also going together towards elimination in the country. So that's what I can say. Despite also some other factors, these areas are areas with Great Lakes, like the areas in the western Lake Victoria, the areas of Kigoma and Katavi, where we have Lake Tanganyika, River Maragaras. And so probably these water bodies, which sometimes might serve as vectors, breeding sites, probably they could also contribute to this kind of transmission situation. But what I can say is it's a mix of things. It's not one factor. Could be suboptimal implementation of the control strategies, but also some other external factors which need to be addressed so as we can move together.
Cool. Well, thank you very much for the nice response. Members of the symposium, if you still have a question, please remember to type it in the chat box or raise your hand so I can see you and call you to ask it. We still have about 20 minutes until the end. Meanwhile, you spoke about the direct observation therapy for administration of antimalarials, and I would like to know if we have any evidence if this is actually being implemented anywhere at any level, especially in East Africa.
I think we have pharmacists who are practicing in the hospital here. They can maybe share with us their experience, but I am aware, because I've been going to clinics, the antenatal care clinics. It's only in the antenatal care clinic where they are given intermittent preventive therapy with SP as a dot. And I like this. They have a very good activity where they have water in the bucket with cups, plastic cups. So they wash them, they give water, and then so it's a good practice which might not be that expensive to implement. So maybe pharmacists who are here will share with us what they are doing in their settings, especially those who are practicing in hospitals.
Thank you very much. Anyone want to give that kind of experience from your practicing area? Welcome. Okay, it seems not to be the case, but at least in antenatal care clinic, they are practicing it. Maybe there are some lessons learned and they can be taken from there to other facilities. But my only concern here was that if a patient comes to your hospital, or you mean the hospital setting here does not include those people who are buying antimalarials in community pharmacy? That's the case?
Yes, of course. But also in the community pharmacy, is required to be the practice. Of course, you can in the community pharmacy, you may not hold patient that for half an hour, but you can at least advise, tell the patient that you make sure that if you vomit the drug within half an hour, you take another dose and then you come and take the other dose, because the dose is 6 doses. The dose of methylmephamphetamine is only 6 doses. So if one dose, the first dose is vomited within 30 minutes, then they only remain 5 doses, for which the 6 dose has to be taken. So the patient needs to buy another dose to complete 6 doses. So I think it's a good thing to embrace in our practice, even in community pharmacy, to just let patients know that if anything happens, the patient vomits within half an hour, they should repeat taking the dose. And also they should make sure that they get the other dose to complete 6 doses.
Okay, thank you. So we have a question from Baraka Simon. Say, I have a concern regarding the management of malaria in community pharmacy, especially the use of IPTP, SP, as optional treatment drug instead of ALU. To what extent we have gone so far to limit the use? You're welcome.
Thank you so much. I think this is very good question, and it's something that we are the main stakeholders on this. Actually, it is explicitly said that SP is not used for treatment. It is solely reserved for IPTP in pregnant women, especially in Tanzania. So, but we still have people. They go to the pharmacy, they ask for SP, they ask for SP, and they use it for treatment, which is wrongly, because of it actually will not help them. I didn't get the question well, whether he's meaning that IPTPSP is used for treatment instead of ALU, or IPTPSP as an optional. Maybe if you can make it more clear. Do you mean that SP is used instead of ALU? Or
Baraka, if you want to ask your question using...
Yeah, you can make it more clear so that I can come in very, very well there.
And you say, regarding the management of malaria in community farmers, especially the use of SP as optional treatment drug instead of ALU. So I think here his concern is people buying SP and instead...
SP, yeah, instead of ALU, yeah. Yes, I think this is a very big problem now, and we have a role of pharmacists to work on this, to tell people that this is not used for treatment. Even in the street where we live or where we come from, we still see people saying that if I get malaria, my drug is metakelfin. I don't have any other drug whatsoever. So we still have those people, those notions in the street, and people come buy malaria. But for example, I have been working in a community pharmacy. If somebody just comes needing anti-malarial drugs, I will not give it without talking to him. I will still ask him whose drugs and why are you buying it? And if it's metakelfin, I will not give it. I will actually advise him, because the ALU is cheap. If he's fearing of price, ALU is cheap. So I think the government wanted to make availability of these drugs, because in most cases in the antenatal care, there's stock out of these drugs. So, but women need them. So the government wanted them to be sold in community pharmacy so that women can still access them, even if they are stocked out in the hospital pharmacies. But otherwise, they would be only given in the hospitals, just like what we do with ARVs. You'll not get ARVs in the hospital, in the community pharmacy. We'll do that, that will be in a better position to control them. But then these are not like the ARVs, and therefore the government wanted to ensure good availability of these drugs to women. That's why they're available in the community pharmacy. So I think it's our duty as pharmacists. Unfortunately, we are not there most of the time, but we train those people we are supervising. We are supervising farm techs and farm assistants. We tell them. Okay. And strictly, because selling SP will not add anything to your sales, but rather you need to help the community by explaining and telling them the truth. I think that is very important. As pharmacists, we need to take role on this.
Okay, thank you very much.
Yeah, thank you.
So I see the hand of Joel Kibona. So Joel, welcome to ask your question.
Thank you very much, Mr. Matias, for the very nice presentation. It was really clarifying and, of course, more educative.
Thank you.
Sorry, but I just have a little bit of concern regarding the ongoing finding the way forward of antimalarial cure and prevention mostly in children. And it was just last few months as we are just finishing the IPTS studies in seasonal prevention of malaria, most in where they are during rainfall season. And as other countries are doing, and we had a little bit of study here in Tanzania based in Tanga, where we used the hydroxychloroquine together with piperacin due to its long malaria during those seasons. But I have just one concern, researchers. Don't we see there could be development of resistance to these kind of medicines as far as when they are using seasonally? Because sometimes we may just distribute it by age or by weight. But I wanted to see maybe if it continues using this periodic, could it have the risk of coming into resistance and could have effect to the society? That this is one which you are depending them maybe on the long-term effect as maybe a backbone after some time, because you're using them when there's prophylaxis and all the preventive care. Could it not have the risk of the resistance in the near future, and generally how is the resistant pattern of the antimalarials. This is another question, how the resistance pattern of antimalarials as far as sub-Saharan Africa is concerned. You can just give us a little bit of the highlight. Thank you.
Thank you, Joel, for nice questions. Welcome, Dr. Mlugu.
Thank you so much, Joel, for very nice question. And I'm also delighted to hear about this implementation of seasonal malaria chemoprophylaxis in our country. And I am aware that that study is going on in Tanga, yes. For a drug to, of course, concerns of resistance are much, especially now when we are trying to expand the role of these drugs, ACTs, in prevention strategies, like in IPTP and also in season of malaria chemoprophylaxis. But for a drug to develop resistance, then we should have suboptimal concentration. Suboptimal concentration of the drugs are the ones that will cause a parasite to develop resistance. So fortunately, the drug that you said you are using for seasonal malaria chemoprophylaxis, which I also use for IPTP, piperaquine component, which is the one responsible for providing prophylactic effect, it has a very long half-life, more than 30 days. It has very long half-life of more than 30 days. And it is only 30 nanogram per mil plasma concentration, which is required to kill parasites. So if you attain concentration above this level, 30 nanogram per mil, then there's no parasite that will survive. And therefore the development of resistance is minimal in this case. So for my case, I saw that the repeated use of these drugs monthly is also associated with an increase in plasma concentration. So there is a gradual increase over every month when you give the full course of the drug for intermittent preventive or for seasonal chemoprophylaxis. Then if you give the first dose this month, then next month you give the next dose. So there's a substantial increase in the plasma concentration. And bearing in mind the long half-life of this drug, then it is said that this plasma concentration, which will stay for longer in the blood, will actually clear any parasite, will actually clear and prevent, clear any parasite which is existing, and also prevent reinfection over that period when the drug is there. So actually, the development of resistance, especially now that we are using these drugs, and didotromycin piperaquine has not been extensively used in Africa. So using it in a control strategy is a good strategy, but rather studies has to be done, Studies have rating plasma concentration, efficacy, and also markers for resistance. So that's what I can say. There is a fear for development of resistance, but with this drug, the fear is minimum, bearing its long elimination half-life and its efficacy. It's proved efficacious. And if it's given correctly, then the plasma concentration is going to be attained, and therefore there's no worry for development of resistance. But also cautions have to be taken. I say that children who are the target of this seasonal malaria chemoprophylaxis, they have high elimination of these drugs, especially piperaquine. There are studies which have reported increased elimination of piperaquine. So if there's an increased elimination, therefore, we expect lower plasma concentration, which would cause suboptimal concentration, and therefore the risk for development of resistance. That should be taken in care. So far, with regard to resistant pattern in Africa, in sub-Saharan Africa, we have few reports. Some of the markers have been reported in Rwanda, and some of the markers have been reported in Eritrea, Ethiopia, and Djibouti around the eastern coast. But these markers have not been associated with treatment failure. So they're just markers to monitor artemisinin resistance, and they have been reported to occur. And these markers were reported in the Far East, and they have been associated with treatment failure. But in Africa, this has not been associated with any treatment failure. So the efficacy of these drugs continue to be high despite even in those areas where markers have been observed. So literally we can say resistance is not a problem yet in Africa. But as we continue to expand using this medicine, and also we have been using them so much for over years, therefore we should expect resistance, and therefore caution should be taken, including more studies to mark these markers of resistance. Then they should be taken over in different places to make sure that we are on track and everything is monitored and informed correctly. So that's what I can say in brief.
Thank you very much, Doctor. With the exception of development of resistance, are there any other factors which you consider can be limiting the implementation of using dihydroartemisinin in piperacin for prophylaxis?
Yes, there is a very prominent marker, the safety issues. Dihydroartemisinin piperacin is associated with the increase in QTc prolongation. So patients with cardiovascular issues might experience significant effects when they use dihydroartemisinin. I have one patient whom I knew, unfortunately she's dead, but she reported to me once that whenever she uses dihydroartemisinin piperacin, she experiences palpitations and all those kind of things. And I remember I advised her and she went to the hospital, and it was the point when she was diagnosed to have the cardiomyopathy. And unfortunately, she died of that. So patients with malaria, with cardiovascular issues might experience those kind of things. But so far, according to the research with this, it is said that dihydroartemisinin also it is associated with the increase in QTc prolongation, but the increase is not clinically significant. So the safe is okay with that. Okay. Similar to other antimalarial drugs which have the same effect, but so the WHO have just offered a document indicating that the cardiovascular effect of dihydroartemisinin is almost non-significant clinically.
Okay.
So that will not be actually a worrying issue so far.
Okay. So we have 5 minutes remaining. Maybe we take the last question from Peter Mabenga. And he is asking, one of your proposals is to develop or invest in developing gametocidal antimalarial drugs. Which gametocytes do you think should be targeted between male and female, and why? And which age and sex of people should be considered for the clearance of parasite gametocyte to block the transmission?
Thank you, Baraka, for this exciting question. I just posed it as actually a research gap that we need these drugs to block the transmission by gametocidal activity. And so far, I am not aware of any drugs in the pipeline which targets this stage. But as I said, we have Primaquine in the market, which kills both gametes, both female and male gametes. And this the guideline, if you have to use with other antimalarial, so you take ALU in the first day, the second day, on the third day of ALU, then you take Primaquine at low dose, so that you block or you kill the gametocytes and block the transmission. So far, that's what I can say. The gametocidal drug known so far is a Primaquine. And with regard to male and female, with regard to gender or sex of people for clearing gametocyte, the issue is that both male and female, when they are infected with malaria, some of the parasites will commit themselves into gametocidal state. Some of the parasites will continue the trophozoite and the erythrocyte cycle, and some of them will commit themselves to developing into gametocyte. So both male and female. But with regard to the issue that I was talking about, pregnant women being peculiar, that pregnant women are more susceptible and the infection is asymptomatic. And therefore, the gametocide, which will, some of the parasites which will commit to gametocide will still, to gametes will still be there, and the women pregnant women who are pregnant, we still carry gametes which will further be transmitted to other people if they get bites with mosquitoes. So with regard to gender, both gender. But then since we pregnant women are more susceptible, then control intervention should be more enhanced to control malaria in pregnancy and consequently controlling the transmission cycle. If I got well your question, that is what I can say.
Okay, thank you very much. We have one hand raised from Rugarabamu Rugundiza, and please make your question brief so that we can close on time. Welcome. Rugarabamu? You are unmuted now, you can speak. So sadly, we cannot hear you. Maybe there is some technical difficulty on your side. And with that, I would like to thank you very much, Dr. Mlugu, for your time and the devotion to present this very insightful talk about management of malaria in Africa. Personally, I have learned a lot, and many congratulations for the completion of your PhD and for these very insightful results which you have brought to the world. And we think it's a good thing that WHO is taking up on some of your findings, and this is the real meaning of research so that it can be useful to the improvement of livelihood in sub-Saharan Africa and other areas of Africa which are affected by malaria. So I'm very grateful for this and for your willingness to share with us. And also thank you for all people who managed to attend the presentation of today. And I believe you will be good ambassadors to share with your colleagues. If Dr. Mlugu accepts, he will share with us the presentation and we can share with you as well, so that you can present at your working place or you can discuss and use it as a point of reference in the future. Dr. Mlugu has a number of very good publications in the area of malaria, and you can take time to search for his name in Google Scholar or any other academic platform so that you can benefit from much extensive data which he found and presented in these academic publications. We are aware that today some of people could not attend because of their involvement in the funeral of our dear friend and brother Prosper Tibalinda, and we are so much with the family and all people who knew Prosper, and we continue to pray for their peace and condolence so that they can recover fast as possible and that the funeral activities go well. And with that, I think I have nothing from my side, and I wish you all the best in your activities, and we shall see each other again in our next symposium. Thank you.